Good morning. Welcome to Grand Rounds, everybody. It's my pleasure to introduce Dr. Bradford Gessner, who comes to us from Pfizer in Collegeville, Pennsylvania. As you know, our division is the Pfizer Center of Excellence in Epidemiology and Vaccines, and he is the Vice President and the Global Lead for respiratory vaccines. He went to medical school at the University of Florida and did residency in pediatrics at the University of Colorado. That was followed by a competitive 2-year epidemiological intelligence service at the CDC, followed by a preventive medicine residency at the University of Washington, at which time he also earned an MPH, and then spent a large part of his career at the Institut Pasteur doing a preventive medicine agency. Part of that was in France. And in the last 5 years, he's been working at Pfizer in vice president roles and has risen to the role that he currently has, which is pneumococcal vaccines and now respiratory vaccines. So he has authored over 300 manuscripts and given multiple major addresses, and it's my honor to introduce Dr. Gessner to us this morning. Dr. Gessner?
Great. Well, thanks for having me. It's always fun to do these talks. And this one in particular is a lot of fun for me because it's just such a new way of thinking about pneumococci and viruses. So the title is The Interaction of Pneumococci and Viruses, Expanding the Paradigm. There is my full conflict to declare. I am an employee of Pfizer Vaccines, which makes pneumococcal conjugate vaccines, as well as is making respiratory syncytial virus vaccines and coronavirus vaccines. So here are the learning objectives. Understand that viruses and pneumococci interact in complex ways to cause disease such as pneumonia and otitis media. Learn basic concepts for evaluating the public health impact of vaccines, and then be familiar with the limitations of relying on etiologically confirmed versus all-cause outcomes when assessing how vaccines work and their impact. Okay, so here's a little background. So there's extensive data that support the role of upper airway viral infection in catalyzing secondary bacterial lower respiratory infection, or LRI, and pneumonia. Most particularly secondary bacterial pneumonia was suspected as a leading cause of death in the 1918 flu pandemic, and RSV may increase pathogenicity of pneumococcus. So there's just a wealth of data on this. Nothing I'm going to say today in any way contradicts that viruses and bacteria interact to cause a secondary bacterial pneumonia. But that's a well-accepted paradigm, so I'm not going to discuss any of the data supporting that. Much less is known about the extent to which bacterial carriage, particularly that due to pneumococcus, which is the primary colonizer of the upper airway that's a pathogen, catalyzes secondary viral LRI. So again, I just want to emphasize that this is the main topic of this talk, which is that things that are going on in the upper airway lead to a predominant viral infection in the lower airway, and possibly even in the upper airway, namely that symptomatic viral disease often is partnered with pneumococci, and in fact may not even cause a lot of symptoms without pneumococci or some other bacteria being present. So there's accumulating epidemiologic, biologic, and clinical trial evidence suggesting this may occur for many viruses. And this is sort of a disclaimer at the bottom that based on all the things that your university sent me to make sure that I wasn't promoting any products, but the vaccine studies, and mainly what I use are vaccine studies, and I've been doing this for 25 years now, using vaccine studies as sort of a vaccine probe approach to learn things about the pathophysiology or epidemiology of the organisms that they're targeted to. So anyway, I'm using those studies to illustrate scientific principles, not to promote any particular use or to make specific recommendations, and indications for PCV use are contained in product labels. So nothing I'm saying here changes any statements about the indications for those. All right, so those are the disclaimers. So first, here are some concepts. They're fairly basic math and public health, but they're surprisingly difficult to integrate into thinking. So the first one isn't so difficult, which is vaccine efficacy or effectiveness. The basic distinction between those two terms is that efficacy comes from a randomized controlled trial and effectiveness is observational or real world. So it removes all of the really strict procedures that are done in an RCT, and it comes from more real world data. Both reflect the specificity of an outcome. So the higher the VE, the more specific the outcome is for the target of the vaccine. So just as an example, VE will be higher for vaccine type pneumococcal cap than all-cause cap. And that's because there's a lot of other causes of all-cause cap, right? So maybe it prevents 70% of vaccine type pneumococcal cap, but it prevents 10% of all-cause cap because there's lots of other things going on, RSV, parainfluenza, more axella, non-typable HI, whatever. The next term is rate reduction, attributable risk, vaccine preventable disease incidence. Those are all synonyms. And that's calculated as the control incidence times the vaccine efficacy or effectiveness, which if you just rearrange terms is mathematically equivalent to the control incidence minus the intervention incidence. So as opposed to the vaccine efficacy or effectiveness, this is a measure of sensitivity of an outcome. So for example, if the vaccine efficacy is higher for vaccine type pneumococcal than all-cause cap, again, let's say 70% versus 10%, nevertheless, the vaccine preventable disease incidence, or VPDI, would be potentially higher for the latter because vaccine type cap would be higher as if other than the random variation because vaccine type cap is a subset of all-cause cap. And you won't necessarily detect every episode of vaccine type cap. So, your rate reduction for pneumococcal cap may be, let's say, 50 per 100,000, but your rate reduction for all-cause cap may be 200. And I'll show you some data on all of these concepts so that you can integrate them. And then, and I'll just emphasize that I consider the VE is mainly a measure of the vaccine and how well it performs. It's not an indication of whether you should use a vaccine or not, because it doesn't tell you how efficient it is for using the vaccine. I think these next two terms, the VPDI and the NNV, are much more useful from a public health perspective. So the NNV, or the number needed to vaccinate, is calculated as 1 divided by the VPDI divided by the duration of immunity. So let's say you prevent 500 per 100,000 cases per year in a vaccine trial, and you show that it has a 5-year duration of immunity, then the number needed to vaccinate is 100,000 divided by 500 divided by 5, which is 40. So literally, that would mean, in layman's terms, 1 case of the outcome is prevented for every 40 people vaccinated over the 5-year duration of protection. And we're going to go through all of these terms in some detail, so don't worry if they're a little confusing right now. So there's 3 major topics I'm going to present here. So the first one is PCVs prevent more all-cause than vaccine-type disease. So there's more going on than when you just look at how much a PCV prevents of vaccine-type pneumococcal X, whether X is otitis media, IPD, or pneumonia. But I'm going to focus a lot on pneumonia and otitis media. So the estimated public health impact of PCV13 adult vaccination in the Netherlands based on data from the CAPITA trial is presented here. So the CAPITA trial was an 85,000 person RCT done in the Netherlands where half of the people got PCV13 and half got placebo, and everybody was 65 years and over. And these are the hospital-treated outcomes, IPD, vaccine type IPD, vaccine type CAP, radiologically confirmed CAP, and then all clinical CAP, regardless of what the X-ray showed. And these are the placebo group incidences, or the control group incidences, and you can see how massively different they are. There was 20 per 100,000 for IPD, all the way to almost 900 for hospital clinical CAP. And then if you look at hospital and community treated outcomes, this is clinical CAP, and this is LRTI, which includes CAP as a subset. And you go from 20 to 12,000, right? So this is just a massive difference in the incidence of the disease. And then you can see the efficacy over here goes in exactly the opposite direction. 76% for vaccine type IPD, down to about 8% for clinical CAP, and then even down to 4% for LRTI. But remember, the formula for calculating the rate reduction is this times this. And so that's how you get this 14.9 in terms of a rate reduction per 100,000. And you can see that the rate reduction, because this number, the increase in this number overwhelms the decrease in this number, that you actually find that you prevent a lot more of these more sensitive but less specific outcomes. So if you just did what most trials have done and looked at vaccine type disease, right, you would have concluded that you would prevent 25 cases per 100,000 people vaccinated of vaccine type CAP and 15 for IPD. But when you include these other outcomes, you see that you're missing really almost the entire iceberg. It's 90+%, because this is 20-fold higher than this is, of the disease is in this category. And even if you just look at the hospitalized disease, it's almost 3 times more for clinical CAP than it is for vaccine type CAP. So there's a lot more than what's being detected by our ability to find this. Now, in the context of this talk, one reason for that may be that our diagnostic tools are insensitive. I won't disagree with that, and as well that people don't actually get the diagnostic test. The diagnostic test may be an X-ray. In this case, it's a urine antigen detection that's serotype specific. For most of these cases, it could be blood culture or whatever. But I'll also show you evidence that some of this, and maybe a major portion of this, is actual viral lower respiratory infection, not vaccine type pneumococcus. And so here's the total number of outcomes, and this is just extrapolated to the Netherlands, showing how many cases that you would prevent. And you can see that if you just looked here, it would really underestimate how many cases you're preventing of pneumonia. 3,800 if you just looked at vaccine type CAP, all the way up to 86,000 for LRTI in both the inpatient and outpatient setting. Whoops. Okay. Just so you know that this is not a one-off, something bizarre that was going on with CAPITA. Happened here, but at any rate, I know what these say. So these are the CAPITA trials, and I just pulled a couple of those data points out for here. And so here you can see the rate reduction, 72 versus 250. And then these are the numbers needed to vaccinate. And remember, that's just taking 1 divided by this divided by 5, or 100,000, sorry, divided by this divided by the 5-year duration. And that gives you 80 here, 277 here. So this was a study done in Germany, a cohort study, and we find that all-cause CAP, the the VE was 12%. The VPDI, or rate reduction, was 211, almost identical to what it was in CAPITA, and the numbers needed to vaccinate were 95. This was both inpatient and outpatient disease. This was a study done by the CDC on the entire Medicare population in the US, so that's 23 million people. So this was the largest study of this type done. The reported vaccine efficacy was 6% to 11%. Against all-cause pneumonia, and the rate reduction was 107 to 103. Numbers needed to vaccinate, again, were right in that range that we saw in CAPITA and this other study in Germany. This was a study led by Joe Lunard. This was a Kaiser Permanente of Southern California, so millions of people, so again, a very large study. Same VE of about 9%. And this was inpatient and outpatient. Vaccine preventable disease incidence was 500. So this looks very similar to what we saw in CAPITA, the number 40. And then this was the last study. I think this was done in the US as well. 10% reduction, and then, oh, sorry, I totally was spacing. I was thinking this was a Korean study. No, this was a study done by Kaiser, Northern California. So Joe's study was in Southern, this one was in Northern California, and essentially the same values. And this is just an inpatient study. That's why these numbers are smaller over here. So in every case, we have this 8 to 12% reduction in all-cause pneumonia, with really large rate reductions and consequently fairly small numbers needed to vaccinate. And I just want to show you on the next, so this is the LRI. Sorry, I thought there was going to be one. I forgot this slide was in here. But anyway, this is just to emphasize the LRI part of it, not the CAP part of it. So remember, we're talking about that a lot of this disease may be viral. And so I want to emphasize, not only is there a lot more pneumonia than you might think based on vaccine type pneumonia versus all-cause pneumonia, there's also reductions in LRI above and beyond what's being prevented in the all-cause CAP. And this actually is mislabeled. This is all-cause LRI, which is what the outcome is over here. So you see 4.4% numbers needed to vaccinate, 35, really low, and then down to 27. And again, this was LRI over here. But this is the slide I wanted to emphasize. So is it surprising that there's a 10% reduction in all-cause pneumonia? I mean, most people would look at a 10% VE and think that that's not very much. I mean, why would you use a vaccine that prevents 10% of a target outcome? But remember that 10% of a disease that's as common as all-cause pneumonia is massive. And it's also much more than what you might predict. So if you look at the 4 studies that were done in the US, the VE against PCV13 type CAP is about 45% from the CAPITA trial. So if you take the percent of CAP in all of these studies that are due to PCV13 types from the UAD and just multiply those out, this is how much you would calculate you would prevent. So 6% in CAPITA down to about 2% in the studies in the US, 3% in the studies in Germany. This doesn't equal the numbers that we're seeing. So in the US in particular, instead of 1.9%, it's 6 to 11% in the CDC study. In the Lunard study, it was 2% versus 8.8%. So you're missing up to 80% of the pneumonias when you calculate it that way. And in sum, calculating the vaccine efficacy from the proportion of PCV13 type CAP and vaccine efficacy against PCV13 type CAP produces a lower estimation against all-cause CAP than is what is reported in real-world studies. And these are all studies in adults 65 years of age, except for this Colditz one, which is 60 years. So the impact of PCV13 may be underestimated because of underdiagnosis of pneumococcal disease and the potential prevention of non-pneumococcal disease not accounted for. And I'm just going to emphasize that this is really a massive decline. And for those who are aficionados of the ACIP, not the most recent evaluation, but years before, 4 years ago when we went to a shared clinical decision-making for PCV, there was no inclusion of this, even though these data were available in the cost models. So the 600,000 per quality save that was reported, or what was called the Pfizer model, which was actually not the Pfizer model, of 200,000 didn't incorporate this either. If these data had been incorporated, the vaccine is actually cost saving. And I only emphasize that, not, again, I mean, people should decide whether they want to use the vaccine or not, but they should use it based on the real data and the real impact that it's achieving. Okay, so moving on. This is a study from Israel, and this is just to show you it's not just in adults. So this was use of chest radiography examinations of probe for pneumococcal conjugate vaccine impact on lower respiratory tract infections in young children. This was Ron DeGan's group, but it was overall seen by David Greenberg. And you can see that PCVs led to decline in CAP, non-CAP LRI, and chest X-ray exams. So this is CAP. This is the standard thing that we think of that PCVs are preventing in children. And you can see that the incidence rate ratio, I'll emphasize here, is 0.68, meaning a VE of about 32%, because 1 minus the rate ratio is the VE. So the vaccine preventable disease incidence would be this times the pre-PCV incidence, because this was a pre-post study, and it would be about 7. So the group also looked at non-CAP LRI, and that's a much more common outcome than CAP, right? But they found the same incidence rate ratio of the pre and post period, so the same VE of about 34%. But the rate reduction is 53. And so what that shows you is that about 80% of what was being prevented is non-CAP LRI, not CAP. And the numbers needed to vaccinate are much smaller for this non-CAP LRI. So there's something going on there that's not CAP. Now, one explanation for this as well, just to emphasize this, is that pneumococcus is not just a cause of CAP. Right, so one hypothesis that's consistent with these data I'm presenting to you is that pneumococcus causes LRI. So when you see a chest X-ray that doesn't have a consolidation, maybe that's the pneumococcus in there. So that would be something that is consistent with the data, but not the way we normally think of how pneumococcus presents. So here's another study that's actually relatively well known in the pneumococcal world, which is the impact of widespread introduction of pneumococcal conjugate vaccines on pneumococcal and non-pneumococcal otitis media. So this is just to show you that this is not just in the realm of pneumonia. And so here you see PCV 7 types plus 6A. These are the extended types in serotype 13. So you can see when they were going down a little bit anyway in Israel. PCV7 was introduced, and then over that year it went down, and then 13 was introduced, and then, it still kept going down because these 7 are in the 13. Here, 19A was actually going up during the year that PCV7 was introduced, and then when 13 came, which contains 19A, everything went down. That's all expected, right? But then if you look at some of these other outcomes, and I'll emphasize, for example, this one, non-typable HI. So when PCV7 was introduced, not really much happened, but when 13 was introduced, there was just a really sharp decline. Culture negative is presumably virus. And so when PCV7 was introduced, not much, then 13 and a big decline, and then all-cause pneumonia, a big decline. And just keep in mind that the axes over here are not the same. So this one is 3 times what this one is, right? So these declines represent a lot more disease than these declines. So you'll see some data later that emphasizes that some of the effects we're seeing on these all-cause outcomes may be serotype specific. And that's why I emphasized that when 7 was introduced, really what you saw a reduction in was vaccine type disease. But when 13 was introduced, then you see reductions in things that you wouldn't expect. Culture negative, non-typable HI, non-PCV13 type disease, etc. And Ron actually calls this the original sin hypothesis. So his hypothesis is that an early pneumococcal infection that's being prevented, maybe 19A, is so bad, the 19A is so bad that by preventing that original infection, it prevents long-standing damage to the middle ear, and that then reduces other causes of otitis media. Consistent with these data, but it's also possible that PCVs are preventing pneumococcus in the upper airway by their ability to prevent carriage, and that's preventing other things that depend on an interaction with a pneumococcus, such as a viral illness. Okay, so that's all sort of conjecture, right? So now I want to show you the next major topic, which is that PCV use is associated with reduction specifically in viral outcomes. So the first study is again from Ron's group, and this is the effect of a conjugate pneumococcal vaccine on the occurrence of respiratory infections and antibiotic use in daycare center attendees. And this is, look at this. Yeah, so this is, I just want to emphasize this first line, and this is upper respiratory infection. So there's a 15% reduction in upper respiratory infection from what was then the experimental PCV9, and this is in an RCT. So this is not just observational data. And I don't know if it's surprising to anyone listening, but a 15% reduction with 9 serotypes out of the 100 that are known for pneumococci implies, in a way, that all upper respiratory infections may be related, or the vast majority may be related to pneumococci, unless there's something very specific about the serotypes that are included in the PCV9 vaccine. I mean, 15% just seems enormous to me. And I don't have the data here, but there's the Finnish FINIT trial found something very similar, that there was about a 15% reduction from PCV10 made by GSK. So it's not specific to a Pfizer product. This is a PCV issue, about a 15% reduction in URI. So this was one of the original studies that emphasized this point from South Africa. Shabir Mahdi and Keith Klugman led this. This was a role for strep pneumonia and virus-associated pneumonia. So I'll just focus your attention over here. And these are the specific viruses they evaluated in the original Nature publication: influenza A, RSV, parainfluenza, and adenovirus. And here's the VE over here. So 45% against influenza A, LRI in South African children, 22% against RSV, 44% against parainfluenza, and 7% against adeno. So these are all fairly impressive, but I'll just emphasize directionality, which is that it was lowest for adeno, so non-significant, next lowest for RSV, and then looked pretty good against flu and parainfluenza. And then these are, these data are all available. This is the HIV uninfected subset, and this is the HIV infected subset. So then Martin Nunes, who works with their group, when the COVID pandemic hit, they went back and looked at their samples for endemic coronavirus. So this is not SARS-CoV-2. These are endemic coronaviruses from the same study that was done years ago. And what they found was something pretty similar. I mean, these data, there are 3 endemic coronaviruses they looked at, and then this is the summary of any coronavirus here. It was about a 34% reduction in any coronavirus LRI in South African children. All right, so right now, so these data in some look like vaccine, PCV9 in this case, was pretty good against endemic coronavirus, influenza, and parainfluenza associated LRI in kids. Now, the way that the authors interpreted this, based on the existing paradigm at the time, was that there was a lot of secondary bacterial pneumonia that was being prevented by PCV, and that it was associated with viruses that they could detect. So that's not the literal way to interpret these data, because that's not how you normally would interpret an RCT. Literally what they showed is that PCV9 prevented viral LRI. And I think that that may have been the correct interpretation. It's just that wasn't a paradigm people were thinking of at the time. So this is a study that we worked on with Kaiser Southern California, which is the prevention of coronavirus SARS-CoV-2 disease among older adults receiving pneumococcal conjugate vaccine suggested an interaction between pneumococcus and SARS-CoV-2 in the respiratory tract. So this is in JID, so you're free to get this. I'm going to just show you 2 slides from this. So this is any COVID diagnosis, COVID-19 hospitalization, and then fatal COVID-19 hospitalization. So these are from less severe to most severe. And then these are the adjusted hazard ratios. And again, if you take 1 minus these, you get the VE. So it's very similar to what Marta Nunes had shown in South Africa. It's about a 35% reduction in any COVID-19 diagnosis. Didn't really make any difference if you got PPV. It was really the PCV13 that had the impact. If you went to hospitalization, it actually didn't look much different. There was no bump in the prevention of hospitalization versus all cause, and there was also no real bump in fatal disease. So because there's no bump, it looks like the interaction, if you believe these data, is at the level of the initial infection. And this goes along with an interaction in the upper airway. And then the other slide I wanted to show you here, this was Joe's idea. I thought it was really clever. I thought it would not show much, and he wanted to do it, and he was right, and I was wrong. And this is looking at the effect of antibiotics. So if there were no antibiotics in the study period, the hazard ratio was about 0.62, so very similar to the overall, so a VE of about 35%. If there were antibiotics more than 90 days previously, in that population, it was very similar to no antibiotics. But if you had antibiotics in the previous 3 months, the effect totally went away, suggesting that there was something going on with the antibiotics that was impacting the ability of PCVs to prevent COVID-19. And by prevention, I mean that there's an association. Now, whether there's a true prevention, I mean, we're collecting additional data to see whether this was an observational, potentially biased finding or whether it's a true finding. Okay, so then lastly, another study from Kaiser Permanente that we worked on together, and this is looking at virus-specific LRI prevention, and it was a case control study, and these are in older adults. And so this is the viruses that they had available in the Kaiser data set, so any respiratory virus, flu A, flu B, RSV, endemic coronavirus. So this was all done pre-2020, so no SARS-CoV-2. These are the endemic coronaviruses. Paraflu, adeno, human metapneumovirus, and enterovirus. So this is the fully adjusted model is over here. And you see that for flu, it's pretty robust. RSV doesn't look great, and adenovirus doesn't look great. And remember that what also didn't look great from the South African study, totally different population, a PCV9 in Africa, in children, was exactly those two, which was RSV and adenovirus. And you can see that the coronavirus and flu and paraflu all looked reasonably similar to what they found, and then they had the addition of metapneumovirus and enterovirus. Okay, so this is all epidemiologic data. Now it is, a lot of the data derived from RCTs, so presumably are not biased if they were done correctly, but there are different ways to interpret those data. Like in South Africa, they interpreted it as showing PCVs prevent secondary bacterial pneumonias that were preceded by viral infection. So is there a are there biologic data that suggests that there's biologic plausibility for this? And recently the answer is yes. So this is the last major topic. So this was the first set of data, and both sets of data come from the Liverpool School of Tropical Medicine, led by Daniela Ferreira. That's this woman right here. So she's the main person leading these studies using a human challenge model. So these human challenge models with pneumococcus are randomized trials, so presumably free of bias. And in the first set of data, the summary is in an RCT of pneumococcus and attenuated influenza virus co-infection. So this is the vaccine, but it's a live attenuated virus. It was observed that experimentally induced pneumococcal colonization impaired the nasal and lung host immune responses, both antibody and cellular, to LAIV when pneumococcal colonization preceded LAIV administration. So I just want to throw that out there again. So pneumococcal colonization doesn't impair the response to the pneumococcus. It impairs the response to the virus when it's in the upper airway. And here's the actual data from that. So this is influenza-specific mucosal IgA and IgA subclasses. And here's if you had no pneumococcal colonization, and here's if you had pneumococcal colonization. And this is IgA to influenza and the fold change from baseline. And you can see just these massive differences in what the IgA response is to influenza based on if pneumococcus was colonizing the upper airway versus if it was not. these go into the IgA subclasses, and then this is interesting because this is if the LAIV came first, you totally miss the effect. It goes away completely. So the pneumococcus has to precede the viral infection. So this goes along with the idea that the pneumococcus is just sitting there in its biofilm in some low density state, waiting to be changed into a high density reproductive state by exposure to the virus. And I'll summarize this in a second. So then we did a study with Daniela, based on her doing this previous one, and it was to look specifically at the interaction between pneumococcal colonization and impaired adaptive immune responses against SARS-CoV-2. Right, so this is to go along with the data that we were looking at from Kaiser Permanente, where PCVs appeared to reduce COVID-19 outcomes. And I know this is hard to see, so I'm just going to summarize it for you. So this is salivary IgA over here, this is nasal IgA, and this is serum IgG. And I'll just draw your attention to these four different things. These are the four proteins, the receptor binding domain, the spike 1, spike 2, and the N proteins for SARS-CoV-2. And it's not the same for all of them, but if you look at pneumococcal non-colonized, which is the blue, and pneumococcal colonized and controls, then what you see is that the effect against SARS-CoV-2 goes completely away for the S1 and S2 for IgA. So it looks just like flu. So control, no SARS, SARS but with pneumococcus, and SARS with no pneumococcus. So it returns to essentially the control state, and it looks just like somebody that had never been exposed to SARS-CoV-2 if pneumococcal colonization preceded the exposure. I mean, that to me is fairly impressive. There's all of these data, and just in the interest of time, because I'm getting pretty close to when I wanted to stop to allow for some questions, are available. And there's additional data that suggests that this is also true of memory B cells. So you'll see there's two different patient populations. There's healthcare workers and patients with SARS-CoV-2 and COVID-19. Memory B cells are also impacted and go down, and this is memory B cells in the mucosa. So this is not floating around in the blood. And then the same thing with T cells. So this is and these are the same four proteins that you see here. And then you can see this group is the group that is uninfected with pneumococcus, and they had a nice robust response when they were a hospital patient in terms of circulating CD4 cells, and these are CD8 cells. So just in summary, and I know I don't have time to go into details with these, but like I said, these data are all published, is that there are declines in IgA, basically back to baseline in mucosal salivary IgA. There's declines in memory B cells, and there are declines in CD4 and CD8 cells when pneumococcus precedes the SARS-CoV-2 infection. And then I had said that there was data to suggest that there is some difference by serotype. So this is just to show you in a study that was, again, led by Ron. You can see Joe Lunard and this Kaiser people, and Ron are two key people in this story. And that's the relationship between specific serotypes and co-infecting viruses. And what they did is they looked at pneumococcal carriage in association with RSV. And this is the percent that were positive for RSV, and this was the percent in respiratory virus negative CAP. And so you can see that it goes from 100% to 100% here. So 33F was always found in association with RSV. Okay, you just didn't see it unless you had RSV. The more invasive serotypes, 1, 5, 4, 7F, these are considered more invasive, especially 1 and 5, were almost never found with RSV. RSV was almost entirely absent when those were seen. and then everything else fell in between. I mean, this is impressive to me that it goes from 0 to 100%. I would have thought it would be in the range of 30 to 50% difference between different serotypes, but just massive differences. So pneumococcal serotypes are not all created the same. Okay. On from that. So what's happening? So here are a bunch of theories that are all consistent. So pneumococcal carriage reduces IgA and other immune responses targeting LAIV and SARS-CoV-2. PCV reduces URI in Israel and Finland. I didn't show you the Finland data, but it's definitely out there. PCV prevents COVID and endemic coronavirus LRI, despite little evidence of secondary pneumococcal pneumonia. By the way, I didn't present these data, but we looked at this a lot when the pandemic first started, and there's very little evidence to suggest there's a lot of pneumococcal pneumonia that's secondary, like there was in the flu pandemic. PCVs prevent 3 to 5-fold more all-cause than vaccine-type cap in the US and Germany and in the CAPITA trial, reduces 7-fold more non-alveolar than alveolar LRI in Israeli kids and 7-fold more LRI than cap in CAPITA, and prevents more otitis media than confirmed by PCV13 type. So here's my theory, my overall theory, just to summarize this, and that's that pneumococcal carriage increases viral pathogenicity by suppressing mucosal immune responses. So I don't know if this is true, but it's a nice story, and the data are consistent with it, which is that pneumococcus sits in its small biofilm. I think it probably is colonizing all of us all the time. Like if you really could swab the entire upper airway of everybody, I think you would almost always find some pneumococcus somewhere, whether it's in the saliva, the nasopharyngeal space, the oropharyngeal space, somewhere. And it's just sitting there in its quiescent state, non-dividing state, because there's little chance of it being transmitted. A virus comes in. The virus actually alters the expression of the DNA of the pneumococcus and changes it from one state to another, and there's evidence for that as well. And so it starts dividing because it sees that it's go time. Now it's got an opportunity to transmit. And if the virus causes, rhinorrhea and coughing and snottiness and all of that stuff, that's when it can transmit, because its existential issue is to be transmitted to the next person before the host gets rid of it. The pneumococcus isn't satisfied with that, at least some serotypes, and so it games the system by reducing the immune response to the virus, causing the virus to have more symptoms. So all the action is in the upper airway. What happens in the lower airway is just incidental to the organisms, clearly important for the host, but incidental for the organism. So the pneumococcus is trying to get the virus to cause a lot of symptoms so it can be transmitted. But by doing that and suppressing the immune response to the virus, it also increases the risk that the host will have a lower respiratory infection or otitis media or maybe invasive disease. So here are some pluses of this paradigm. It's parsimonious. Pneumococcus doesn't have to cause URI, and we don't think that it's the main cause of URI. We think viruses are. Continues to present largely as alveolar consolidation. It's an explanation for the association between PCV and reduced viral outcomes. It's the simplest explanation for some of the RCT data, for example, in South Africa. And it's also consistent with the evolutionary pressures on pneumococci and viruses, that they would interact, that they would develop in ways, because they're both so common, that they would evolve in ways that allowed them to utilize each other to be passed on to the next host. There are some issues that remain to be worked out, so it requires continued vaccine-type circulation despite pediatric PCV use. This is now well documented. It's a complete myth that PCV use in pediatrics takes care of vaccine serotypes in non-vaccinated cohorts. PCV use in pediatrics greatly reduces vaccine-type circulation in unvaccinated cohorts, but it doesn't by any means eliminate it. There's still plenty of disease going on from vaccine-type pneumococci. This paradigm requires higher adult carriage levels than previously reported. There are some studies in the US that show 1 or 2% carriage, but there's increasing data with modern techniques using PCR and using different sources. So studies used a pediatric paradigm of the NP swab, And it may be that most pneumococci don't live in the NP space in adults. That may just be a pediatric niche. And so if you test saliva and the oropharynx and use PCR, you can find pneumococci in a point prevalence, not longitudinal, but just point prevalence of up to 40%. And again, maybe everyone always carries pneumococci in varying degrees inside or outside of a biofilm. And then it requires that action varies by serotype, because it wouldn't make sense that we would see these big effects with PCV13 when PCV13 only reduces, presumably, PCV13 serotypes and maybe a few cross-reactive ones. And there is evidence that different serotypes interact with viruses in different ways. And maybe this is one reason that some serotypes are more fit, and the 100 serotypes are not equally distributed in human populations. Not the only theory or the only component of a comprehensive theory. Strep don't care about our classifications, and they promiscuously exchange DNA. So maybe, and along with that, a substantial amount of upper airway pneumococcal capsule occurs on non-pneumococcal streptococci. So they have the gene for the pneumococcal capsule, and maybe they're involved in some respect in what's going on. And by having a vaccine that targets the capsule, we're affecting this as well. On the other hand, most non-pneumococcal streptococci do not have a pneumococcal capsule, so I'm not sure that that's the best theory for what's going on. But if it is important, if the capsule itself is important for immunologic modulation, it could explain the impact of PCVs. Another idea that we're looking at is that our UAD may be massively insensitive, so very specific, and it was designed to be specific. And the urinary antigen detection test is the main way that we identify non-bacteremic pneumonia due to pneumococci, and if that's really insensitive, it could explain some of these data as well. So we're working on all of these theories. And regardless of a solid explanatory model, some facts are reasonably solid. Pneumococci and viruses interact in the upper airways in ways that increase the risk of lower airway disease. PCVs prevent disease by generating an immunologic response against vaccine-type pneumococci. We don't think that they're generating some strange antibodies that specifically target viruses. PCVs, I think, work by preventing pneumococcus. PCVs prevent more disease than accounted for by etiologically confirmed disease. I mean, I just think is one of the key points. Whenever you see rate reductions or cost models, you should always look and see whether all-cause disease is being accounted for or only what's being identified by a diagnostic test. PCVs are associated with reductions in virally confirmed LRI, and pneumococcal carriage is associated with reduced mucosal immune responses to some viruses. And I believe that's it. Thank you.
Thank you, Dr. Gessner. I'll start off with the questions. And my question is actually about PCV20. You showed us data that there's some serogroups of pneumococcus that if they didn't go down after PCV7, then they went down after PCV13. There's some non-vaccine serogroups that actually increased after the introduction of some conjugate vaccines. So my question is, what do you predict will happen with the introduction of PCV20?
Well, the simplest prediction is that the 7 new serotypes will go down, right? So I think that that's pretty clear. There's not any evidence that the immunologic responses we see in the new vaccine are in any way different. And so those new 7 serotypes, 22F, 33F8, 10A, I mean, all of those are going to go down in IPD. We'll see less of them in pneumonia. So the urinary antigen detection test now is geared up for those additional serotypes. So we'll be able to monitor those. The question I think you're asking is, will you see this big bump in non-etiologically confirmed disease that we saw with 13? And that we didn't really measure very well with 7. And that, I think, is a mystery. I have no idea if the new 7 are going to look like the new 6 and 13 beyond 7, whether they'll look like the original 7, whether those are ones that interact with viruses. Like some of them do. Like you saw 33F was all the way on one end. Like it only interacts with viruses. So maybe there are some of these serotypes that will see even bigger effects. There's more invasive ones like 8 and 12F that may interact less with viruses. So those may be at the other end where we don't see much impact on them. I think it will not be any less than 13. So if you look at the all-cause pneumonia impact, it's about 10% in the US in older adults in the context of a PCV 13 program for children. So that's the additional benefit you get from vaccinating adults. It will be at least that. And it may be more than that. It may be 12, 13% if there's some impact of these 7 on interactions with viruses. And by preventing carriage of those organisms, you impact viral disease.
Okay.
So that's a long-winded way of saying I don't know, but we're going to monitor it.
Yeah.
So we
No,
have
that's okay.
Yeah.
I'd like to open it up to people who want to ask their questions over the audio. If they want to unmute, Jason, can they do that?
Yes, they can unmute and ask. And actually, we've got some, and if they want to type a question in the chat area, they can do that as well. And we actually have a couple in there, and I'll read them off for you, Dr. Gessner. One is from Dr. Robert Emmons. He's in our bone marrow transplant group in the oncology hematology. And he wants to know, is there evidence that pneumococcus work to some degree like the measles virus to reset the immune system? Do we know anything about which microbiome constituents compete best with pneumococcus in terms of colonization?
Yeah, so I know that the measles story is a great story. I mean, resetting the immune response. So, there was a lot of data, for those who don't know that story, that measles vaccine had some non-specific effects, and there were people that really were on board with the measles vaccine is causing all these non-specific effects. But it turns out, and the reason they said that was because all-cause mortality in Africa just plummeted in people that had received measles vaccine. But it turns out it's a specific effect of measles vaccine on measles virus, which is that when you get measles, it resets your immune system to naive of many of your responses, so that you look like somebody who has not previously been exposed to these organisms. So there's no evidence that I know of that pneumococcus does that. So that's the short answer. It's an interesting question. So yeah, what was the second half of it? Sorry, I know there was
sorry, yeah. The second half was, hold on, let me make sure I got it right. It says, do we know anything about which microbiome
microbiome? Yeah. So, well, right. So there's not, I mean, pneumococcus wouldn't be so prevalent if it wasn't something that competed well. And I think that the reason it competes well is because it has the ability to just sit there for long periods of time, probably in a biofilm where it's protected from the host immune response, and it just sits there waiting. And a key piece of evidence for this actually came from the pandemic, where IPD, due to pneumococcus, essentially disappeared when respiratory viruses went away. So if you look at IPD rates during all the non-pharmaceutical intervention measures like isolation and mask wearing and all that, IPD disappeared. But if you looked at pneumococcal carriage, it never went away. So all the carriage studies, and there were a few that were done, showed that pneumococcal carriage persisted. And there were predictions in England that pneumococcal disease would stay away for years. And in the US, they said it's going to come back with a vengeance really quickly. And the US was right, and the UK was wrong. Pneumococcus has come back really rapidly. And the reason is probably because pneumococcus just sits there and much longer than people had anticipated. So I think, the answer is there's only very early work being done to look at the whole microbiome and the interaction of pneumococcus with that and how that plays into roles of vaccines. But I think that pneumococcus competes very well with other organisms, and that's why it's such an important pathogen.
All right, and actually, Dr. Emmons had a question that was a little higher up than that, but I missed. But he wanted to know, can you comment on how pneumococcal colonization might affect immune response in immune-compromised patients, especially those with poor vaccine response? What should we be doing in that population? Possibly antibiotics? ?
Yeah, I mean, I don't know that there's any evidence that antibiotics to eliminate pneumococcal colonization. So this is, by the way, a strategy used in meningococcal outbreaks, right? So if you see a case of meningococcus, then you go out and give antibiotics to the household to try and get rid of that particular strain of meningococcus. But if it's the case that pneumococci are everywhere and you're always getting exposed to them, I'm not sure that giving antibiotics will do much except increase the spread of antibiotic-resistant organisms. Now, that said, there's very little data, which was surprising to me when I started this job, on immunocompromised patients and their immune responses to PCVs. The PCVs are specifically designed for improving immune responses in people that are immunologically compromised, I guess. So children under 2 years of age and older people who are immunosenescent. And there are data that they work well in people that are immunocompromised. So Louisville actually provided the best data on that, where the vaccine efficacy was 70%. In an observational study, so PCV13 against vaccine-type pneumococcal pneumonia based on UAD, and the 80% of that population was at risk. So at risk are things like COPD and heart failure and things like that, and 40% were in that group, and another 40% were in the immunocompromised group. So some type of immunocompromising condition, whether it was chemotherapy or whatever. And when we adjusted for those factors, we didn't see much reduction. That's not direct data. Like, what would be great would be to have direct evidence that in an immunocompromised population, VE is X. And we're trying to collect those data. It's just that it's a relatively small population. And when we look at IPD, there's not that many cases. So it takes a while to accumulate the data. So the best thing to answer the question, I think, to do right now is to use vaccines in immunocompromised people. There may be some benefit to booster dosing, giving an additional dose. That is not an on-label comment. We're evaluating whether giving boosters is beneficial, and that includes to people who are immunosenescent, the people that are in the older range of older, so 75, 80, 85, but more data to come on that.
All right, and I see Dr. Burns popped up. Did you have a question, Dr. Burns? Okay, never mind. Another question is from one of our retired researchers. He says, a great talk. He said, what would you say about would you say that pneumonia inhibits IgA in nasal mucosal tissue and contributes to breakthrough infection?
If the question is, does pneumococcus inhibit nasal IgA? Yeah, then yes, I think that it's not. So the original idea that I thought was that there's an IgA protease that pneumococcus elicits. And I thought, well, that's the answer. Pneumococcus is eliciting this IgA protease. It's directed against the IgA to viruses. That's how it's gaming the system. But that's why I showed you the IgA1 and 2, because it's an IgA1 protease, and both IgA1 and IgA2 go down in the presence of LAIV, so influenza vaccine, the live attenuated influenza vaccine. So yes, there is evidence now from 2 viruses, and we're looking at another study to look at this as well, that pneumococcal carriage inhibits IgA against the virus. And again, I'll emphasize it's not IgA targeting the pneumococcus, it's IgA targeting the virus that the pneumococcus impacts. But it's not just IgA, so it's the memory B cells and the T cells. And I didn't show these data, but it's actually inflammatory markers as well. So, and inflammatory markers are part of the innate immune system instead of the adaptive. It's not targeted to anything in particular, and those are things like interferon. And so it's a pretty broad range of impact that pneumococcus has on the immune system when it precedes the viral infection. And, another interesting part of this, by the way, is not just thinking about pneumococcus, but viruses. Maybe many of these viruses are just benign in the absence of pneumococcus. And it's only because pneumococcus is able to adapt the upper airway immune response that we get symptoms from these viruses.
Well, thanks, Dr. Gessner. As you know, Louisville is the home of the slugger, and so we'll be
Mhm.
shipping you a slugger bat with University of Louisville and today's date and the name of the
Really?
lecture.
Yeah,
Awesome.
Yeah,
gonna
so
look something like this.
Fantastic.
there you go.
Nice. I love it.
Not sure if you're a baseball fan, but we're
Yeah.
gonna
My dad
make
was a
you
college baseball player, so yeah, he'll like it even
okay,
more.
perfect.
Cool. All right. Well, thank you so much. And Dr. Arnold, thank you for facilitating and inviting such a great speaker. Dr. Gessner, thank you for an outstanding talk, and we really appreciate it. Dr. Arnold, do you have anything you'd like to wrap up with? Or
No, just thank you and hope to see you again.
Yeah, thanks for inviting me. All right.
thank you,
Bye
Dr.
bye.
Gessner. We appreciate it. And
Great lecture. Thank you.
All right.
thank you.
Bye.
And just let everyone know, of course, we're kind of winding down for grand rounds this year, but we still have a couple left. Next week, Dr. Callan in dermatology stepped up. We're going to have, and we'll be inviting Dr. Misha Rosenbach from the University of Pennsylvania, and we'll have him in next week on at the same time. So May 12th at 8 a.m. And I think some doggies here woke up a little bit. So anyway, thank you everybody. We'll see you next week, and we